definitely say that it was that special interest in psychedelics that kind of drove my educational path around drugs and kind of the ultimate journey to become a pharmacist. So I have a website, spiritpharmacist.com. If you want to talk individually about a situation, I do some phone consultation there. If you just want kind of just drug information, you want like a written type response about general situations, you know, methadone versus MDMA, what's the difference, things like that. Also beginning to work, I should say, with some retreat centers, particularly one in Amsterdam, to kind of help them develop some protocols around using antidepressants and psilocybin truffles, because they've noticed such a massive uptick in the number of people that are wanting to use psychedelics that are on mental health medications. And I think that if there's really anything that I'm trying to do in this field of psychedelics or field of plant medicine is be the sort of bridge between a traditional mental health interface and the world of psychedelic drugs, because, spoiler alert, a lot of the psychotropics really don't seem to mesh or meld very well with psychedelics, yet they almost universally cause some type of at least physical dependence, if not psychological dependence or habituation as well. So it's this sort of, how do we get someone that's kind of in one world of traditional mental health care on these psychotropic medications and get them to the place where they can use a psychedelic or use a psychedelic as a healing vehicle safely. So I have several blogs now on different types of psychedelics and classes of psychotropics. And I'm going to continue writing these blogs and hopefully use them all for seeds as kind of like a guide or a book chapter, or to kind of create like a guide or like a handbook out of them. I did a psychopharm lecture series this last fall in Los Angeles, so this talk tonight is very similar to the 5th installment of that, which was on drug interactions and psychotropics, and I'm going to convert those to some online courses. And then there's just so much that we don't know about psychedelics and psychotropics. Is like, I want to try to do some research. There's so many people that are, you know, having these experiences here and there. We have things like mystical experience questionnaires, the Shulgin scale, kind of like a 1+ to a 4+. So we have sort of some ways that we could start asking questions about the intensity of people's experiences when they're mixing them with certain things, and hopefully that will yield something interesting that will be helpful. Okay, so this is kind of our outline tonight. I'm going to start with a little bit of an introduction into what drug interactions are, talk a bit about mental illness and the psychotropic kind of interface, and then we'll kind of dive into just sort of like what types of interactions are out there. And I tried to structure it so that there wasn't so much material that I talked like 20 minutes over, because that's my standard sort of tendency. So if you have questions at any point, please just kind of interrupt me, because I can tell from the round of introductions we have a lot of really high quality people here with experience in this types of things that are already doing this type of work. So, you know, teach me if you have something to teach me, please. Okay, so when we think about the ways that drugs interact in the body, there's a few different types of things that we could think about. And the first is a pharmacodynamic type of interaction. This could mean that basically two drugs are doing similar types of things, or maybe counterproductive types of things, but they're doing it at the place where the drug acts in the body. So like a very basic type of interaction would be something like, well, opioids are sedatives and alcohols are also sedatives. Or benzodiazepines are sedatives and so is alcohol. So yeah, you put those things together, you get more of a sedative type of effect. That's just a very simple type of pharmacodynamic interaction. The other one would be pharmacokinetic. So this is the way that drugs are metabolized in the body. So this could be that a drug is affecting somebody's kidney or liver in a way that prevents the other drug from being metabolized. And now that drug is kind of stuck in the body and able to cause more effect for a longer period of time than what we normally expect. This is a really big one that I think like people really should keep in mind and not forget about in all of this. Is I get so many questions around hey, this person is on this cholesterol drug and this antihypertensive medication. Do they interact with psychedelics? And the answer is no, not really, but that regimen is kind of screaming coronary artery disease, right? So you kind of think about like, well, you know, that essentially would be excluded from a clinical trial. And I'm not trying to say that no one with coronary arteries should ever use a psychedelic, but kind of thinking about like, well, first and foremost, before we assess what drugs somebody is taking and how those interact, let's just talk about what type of illnesses, what type of disease states they have, and how severe they are as far as getting an idea of who this person is and how medically fragile they are as far as like thinking about this. And I think especially when we kind of talk about entheogens and end of life, kind of, you know, working with someone that does have advanced illness, like these questions need to be thought out. And then, of course, there's mixed types of interactions. There's several SSRIs that interact with psychedelics on pharmacodynamic types of levels. So they're competing at the serotonin synapse as far as a mechanism, but then they're also inhibiting psychedelic metabolism in the liver. So some drugs are just kind of double whammies in that they're interacting in multiple types of ways. Okay. So let's talk a little bit more about pharmacodynamic interactions. Again, you could have some that kind of cancel out. You could have some that kind of potentiate. And potentiation could be a good thing, it could be a not so good thing, right? So, you know, the kind of, I really should have used plants, because it's plant society, right? I need to know my audience here. But mixing MDMA with LSD, the candy flip or hippie flip, pretty classic type of psychedelic adventure. Definitely a potentiated type of experience, but you know, doesn't seem to necessarily drastically increase the physical risks to combine them together. So that's maybe an additive type of thing. There's synergistic. So additive would just be sort of like a 1 + 1 = 2. Synergistic now is like a 1 + 1 = 5, right? So that would be sort of like, okay, like GHB and alcohol is just, you really just don't want to mix sedatives with GHB because it tends to kind of synergize with them and take you from sedated in a way that you might find euphoric to not breathing very, very quickly, right? So especially with some of those sedative types of interactions, things like GHB, you got to watch out for synergistic types of experiences. And probably things like MAO inhibitors and MDMA is going to be another one that's kind of synergistic and ends up being toxic, ends up giving you potentially serotonin syndrome. The other one is sort of like a diminished interaction or a diminished effect, and it seems that with SSRIs and some of the other plant medicines like psilocybin mushrooms, fungal medicines, it's kind of a mixed bag. Some people get an effect, some people don't. MDMA seems very classically like it really kills the experience. So I've been playing around with this little program I found called BioRender, where you can kind of make these little synapses, and it's super cool. I think I'm gonna, this is just a free version right now, but I think I'm gonna get a subscription because you can literally just make any type of scenario in a neuronal synapse you can. And you know, I've scoured the literature looking for really cool neuronal synapse models of psychedelics, and they're kind of out there, but it's very hard to find one that's like just demonstrates the situation that you're hoping for. So this is a serotonin 2A synapse. The serotonin 2A receptor is the subtype of serotonin receptor that seems to be integrally important for a psychedelic to stimulate, to have a psychedelic effect, at least if you're talking about serotonergic psychedelics. If you're talking about ketamine or ibogaine, the mechanism seems different. I don't want to like cut this side off. I feel like I'm kind of...
Oh, you're good.
You're good? All right. So you kind of have a few players here. Serotonin is synthesized from tryptophan to 5-hydroxytryptamine or 5-HTP, and eventually it becomes 5-HT or serotonin. 5-hydroxytryptamine packaged into a vesicle here by this guy called VMAT2, or vesicular monoamine transporter. So serotonin packaged into a vesicle, and normally what would happen, you would get some signal that comes down the neuron, and the vesicle would release serotonin into the synapse. Now, once serotonin's in the synapse, it's free to act or bind to its postsynaptic receptor, so the serotonin 2A receptor, and you get some signaling effect here. It can be degraded by monoamine oxidase in the synapse, or it can be reuptake back into the presynaptic terminal by the serotonin reuptake pump. And in here, it could be repackaged in a vesicle, or it could be metabolized again by monoamine oxidase. So this is kind of what you're looking at under a normal circumstance and kind of how things work. So let's throw some MDMA in the mix now. And MDMA, it does a few different things, and this is reductionist as far as MDMA's mechanism. It has neurohormonal effects. It also releases dopamine and norepinephrine. So this is just kind of like looking at just the serotonin types of effects of MDMA. But MDMA does a couple of things, and we think primarily what it does is stop the packaging of serotonin into vesicles. And this causes a release or dumping of serotonin. And normally serotonin is released into the synapse by these vesicles, but when MDMA is preventing serotonin from being packaged, it's causing this dumping or releasing of serotonin. It actually is released out of the serotonin reuptake pump. This is called carrier-mediated release. So normally, all these pumps, they work on gradients. They just take things from something to a high gradient to a low gradient. So normally, because serotonin is packaged in this vesicle, there's a very low gradient of serotonin in the presynaptic terminal, and there's much more in the synapse. So all the reuptake is going this way. But under the influence of MDMA, it seems that it gets released out of the serotonin reuptake pump in a carrier-mediated release. MDMA can also bind directly to serotonin 2A receptors. It seems that it binds this receptor fairly weakly, so it's kind of, you'll meet some people that are kind of like, I think serotonin is primarily a releaser. The kind of action directly at postsynaptic serotonin 2A receptors is maybe less. So this is MDMA, primarily a serotonin releaser. Okay, so what do we throw an SSRI in the mix now? So a lot of the times, especially in the depression microdosing forum online, it's always MDMA and SSRIs or psilocybin and SSRIs equals death and serotonin syndrome. And I mean, I've yet to find a case report of either of those drugs mixed with an SSRI that cause serotonin syndrome. I can find pharmacokinetic clinical studies where they mix them in a lab setting, which probably wouldn't occur if there was some risk of serotonin syndrome, because that seems like it would be a pretty unethical experiment to do in human beings. So I'm pretty convinced that that's not the case. What happens here is you've got an SSRI, or a selective serotonin reuptake inhibitor, and these drugs are pretty selective, but extremely tight binders at the serotonin reuptake pump. So now you have this SSRI that's bound the pump. MDMA is trying to release serotonin, but the pump is blocked. It cannot release serotonin into the synapse anymore, and the serotonin is simply just gobbled up by monoamine oxidase in the presynaptic nerve terminal. So the intrasynaptic, or the amount of serotonin in the middle of the synapse, remains pretty much the same. This relatively the same. Whatever that person was experiencing on the SSRI is more or less unchanged by MDMA when they're on the SSRI. Even without the SSRI there's some potential, and this is, I think, the kind of the black box of SSRIs and psychedelics, because antidepressants or SSRIs do not work immediately. They take a long time. They take 4 to 6 weeks. There's some type of long-term neuroadaptation event that needs to occur. We think that it actually has to do with a different synapse, more serotonin 1A, but there is some evidence that chronic SSRI use might get rid of these serotonin 2A receptors. So if you kind of had these receptors downregulated or unavailable, maybe you wouldn't get an effect. And this is kind of where, getting ahead of myself. But if you kind of think about the elimination or washout time for SSRIs, with the exception of Prozac, they're all gone from your body within 2 weeks. So does that mean that 2 weeks is the optimal amount of time to wash out an SSRI before using a psychedelic? And that's where I think we need more data. Because if someone's really been taking an SSRI for years, and it takes 4 to 6 weeks to get a therapeutic adaptation event, maybe it also takes 4 to 6 weeks for them to come back to some type of homeostasis. And certainly the withdrawal syndrome from SSRIs has not fully run its course in 2 weeks. It's usually 7 to 10 days is kind of the peak of it, right? And sometimes these withdrawal syndromes last a month and people have on and on for months afterwards. So that's kind of the black box, I think, as far as kind of thinking about the time the drug is eliminated. Okay, I'm not worried about any type of counterproductive or toxic interaction, but knowing the chronicity that someone's taken this and knowing that there likely was some type of adaptation event, should you also wait some period of time afterwards? I'm not sure. Let's go, the last one now is MDMA with MAOIs. So in this case, monoamine oxidase is taken out. So it's black here, and it's blocked in both places. It's blocked in the presynaptic terminal, it's blocked in the intrasynaptic cleft. You have serotonin leaking out of the vesicle because of MDMA. It's being dumped into the synapse, so you're going to get more serotonin dumping than normal, and now your body just cannot get rid of it. It cannot get rid of it in the synapse. It cannot get rid of it in the terminal. You got way too much serotonin here, and you've got some kind of toxic type of signaling. So I just threw these in here because they were fun, and I've just been like working on them over the break, like working with this kind of program. But I think that it has the potential to make something like kind of complicated easier to see visually. But maybe you need some biochemistry or something I'm not sure. Pharmacokinetic interactions occurs when two drugs are mixed that interfere with the metabolism of one or the other. It primarily occurs in the small intestine or liver, although it could occur in neuronal synapses. So monoamine oxidase is one of these ones where it's like, I don't know, do you want to call it a pharmacokinetic interaction or do you want to call it a pharmacodynamic interaction? It's really both of them, because monoamine oxidase is in your small intestine, it's in your liver, but it's also in those nerve synapses. So it's doing both things. Monoamine oxidase is involved with initial metabolism of drugs when you ingest them by mouth. Monoamine oxidase is involved with metabolism at neuronal synapses as well. As far as candidates for drugs that are going to be problematic from a pharmacokinetic perspective with psychedelics, beyond the monoamine oxidases, CYP2D6 inhibitors, I think it's the next slide, yeah. So here's your liver. Under normal circumstances, you have a drug, and they have certain liver enzymes, and I don't know, maybe you're familiar with these, maybe not. They call them cytochrome types of enzymes, so these CYP2D6, CYP3A4, they sound extremely complicated, but it's basically just an enzyme that breaks down the drug into a metabolite. That's all CYP2D6 is. So a drug normally breaks down to a metabolite. In the circumstances where your liver metabolism is impaired, and this could be because you took some type of CYP2D6 inhibiting drug, it could be because you have some type of genetic deficiency in CYP2D6. About 10% of Caucasian people have a poor metabolizer or a genetic deficiency in CYP2D6. It could just be because you have, you're 85 years old. As you age, your liver and kidney function tend to slow down a little bit. Or it could be that you actually have some type of liver illness. Perhaps you have cirrhosis or an advanced type of hepatitis C, something like that, and you have compromised liver function. Maybe you have a stage 4 cancer and there's a metastases to the liver or something like that. Yeah?
I forgot, is grapefruit part of that or just P450?
So grapefruit juice inhibits CYP3A4, and it is in the small intestine and liver. How that would affect many psychedelics, I'm not too sure, because I don't think many of them go through CYP3A4, at least initially. You also have to drink quite a bit of grape juice on a fairly consistent basis for it to really kind of make a difference for you. But if you really like grape juice and you're drinking, a pint or two every morning, that is something that you probably should report to your doctor if they're prescribing you drugs or medications, because it can affect the pharmacokinetics of drugs. So this one's a Wellbutrin. Wellbutrin is a dopamine norepinephrine reuptake inhibitor, so it does not work on serotonin. And sometimes this is taken to mean that it's a green light. Doesn't work on serotonin, doesn't seem to strongly interact as far as the psychedelic effect, so we're good to go, right? Well, maybe, maybe not. Bupropion inhibits both CYP2D6 and CYP2B6. So you got MDMA over here. CYP2B6 could convert it to another active metabolite, MDA, but all roads lead to CYP2D6 here. Right? So if you're going to block CYP2D6, you're going to get more MDMA probably for a longer period of time. And that's what you saw. In this study, they saw, looks like, I just estimated based on this, it looks like 200 to 240, about a 20% increase in the concentration of MDMA. And you see that there is this extended duration of effect. And this is the graph for blood concentrations in the paper. They also have graphs for drug liking, good drug effect, and those very much match the blood concentration. So it seems that people's experience match what's happening in their blood for the most part. MDMA has not caused a seizure in clinical trials. MDMA has caused seizures in recreational settings. That could be impurity of drug, it could be hot nightlife type of setting, it could be dehydration, it could be that MDMA wastes sodium so that you're kind of a little bit electrolyte depleted. So there's several reasons why MDMA could lead to a seizure. Wellbutrin or bupropion is contraindicated in epilepsy or seizure disorders as well as anorexia or restrictive eating disorders because it does lower the seizure threshold. So again, I'm not trying to be like a really scary type of person here. It's like, okay, MDMA-assisted psychotherapy would be too dangerous for somebody on Wellbutrin, but I don't know. There's probably an increased risk of seizures, and you know that they're going to have a stronger experience for a longer period of time. So if you're not going to straight up avoid it, it seems it would probably be reasonable to reduce the dose of MDMA by 20 or 25%, something like that. So I think this is where more data is going to be very helpful in kind of guiding, like, how do you manage these decisions? Do they always have to stop? If they're not feeling well at baseline and you're asking them to stop, you know, how is that going to work? All right, talking too long in this section. Renal drug interactions, it could be an issue. Drugs are filtered through the kidneys and are eliminated by the kidneys. There's not so much metabolism that is actually happening at the kidney. I kind of think that this is maybe more of a problem with long-term or kind of intermittent or chronic use of medication. They tend to accumulate in the kidneys over time because you can't really get rid of the metabolites. But in clinical trials of psilocybin for life-threatening illness, when they did use primarily cancer patients, they did exclude anyone with any type of compromised liver or kidney function. And is that always realistic? I'm not sure. In pharmacy, we just dose reduce. So it's like someone has bad kidney, bad liver, there's usually some type of dose reduction that can be done that basically makes whatever their metabolic capacity kind of match the dose that you're giving them. Okay, so I kind of talked about the antihypertensive. Like, does it interact? No, it doesn't, but you should worry about the person's blood pressure because that is essentially one of the criteria that they do care about. Almost all psychedelics raise your blood pressure transiently. Some of them, like MDMA in recreational settings, there are reports of cardiovascular events. Things like psilocybin mushrooms, there really is very, very little to support that they actually lead to cardiovascular events, this kind of transient rise in blood pressure. But you know, at this stage in the game, we're just trying to be cautious and make sure that everyone is safe. At any stage in the game, really, but I think on the precipice of legalization, we just don't want cardiovascular disasters. You know, you can kind of think about other things, right? Like, especially like plant medicines, right? Like MDMA, psilocybin, I don't know, they usually don't have you fast for 24 hours ahead of time and things like that, right? But for someone with diabetes, you know, how realistic is it that they do a dieta? Maybe they really do need to do a dieta, but you probably need to kind of maybe like modify it, or if it's going to be this kind of week-long retreat and the kind of standard is to eat, you know, one bowl of soup in the evening time. You know, maybe you have to allow that person with diabetes to snack on sugars or maybe some protein, some kind of things during the day, and you know, just kind of work with them, just kind of think about it. You know, saying, you know, people have lots of hip and back pain, and you know, the standard is for everyone to sit cross-legged like a yogi for 8 hours in a row. You know, that might be not the best for that person's setting, as far as it could just be so uncomfortable they can't participate. Mixed interactions I kind of talked about, as far as, you know, some interact at liver levels as well as the synapse. Rare and risky, so this one's, you know, another thing that's kind of like, yeah, you can mix MAO inhibitors and 5-MeO-DMT. I did it. My friends did it. It was profound. You got to try it, man. And the other voice says, that's toxic and you're going to die, right? And then there's a big debate online about like whether you will die or you won't die. And it's kind of like, okay, well, the reality is that somebody died. You know, I don't know what dose it was, what route it was, how much time elapsed between them, what their CYP2D6 status was, right? So there's some risk in here somewhere with this combination, but the doses and routes I'm not exactly sure. So, you know, kind of like, these are made up numbers. I don't really know what the numbers is, but let's just say a drug combination has a chance of death of 1 in 500. Well, that's 0.2%, right? So that means there's going to be almost 500 people on the internet raving about how awesome it was, right? And then there's going to be one person whose voice is permanently missing. Yeah. So I think the kind of point here is that polling the Facebook forum group that is full of people that are just dying to tell you about how awesome their experience is, because that's why they hang out in the group all day, because they've only had awesome experiences, is probably not the best way of kind of thinking about this type of stuff, and sort of thinking more of like, all right, well, someone did. It sounds sort of risky. You know, maybe you really have nothing to lose. Maybe you've been thinking about killing yourself for the last 15 years. And you know, you don't have a lot of family around, and you're kind of like, you know, okay, 1 in 500. Like, I'm addicted to heroin. Like, yeah, I think 1 in 500 chance of dying with this drug combination that could really be helpful for me is worth it, right? Whereas if you're a facilitator and you're, you know, pouring a cup for 25 people 2 nights in a row on a weekly basis, I mean, you're going to serve 500 people in a year. So that's not going to be an acceptable risk for you, right? So again, you know, there's no right or wrongs. There's just who you are and what the risk is and your decision. Yeah, Ryan.
One question. Is there actually a database that has the listing of all the people that have died during trials, programs, combined, anything?
Trials? Nobody's died in clinical trials.
No outliers, nothing?
Not permitted.
Not in clinical trials with these psychedelics, no. But, right, it would be reasonable to have this database, right? I don't know, Richard, do you know anything about like a database of ayahuasca deaths? Like,
I have one.
yeah, Richard has one, email him.
In the clinical trials involved in the fast tracking of esketamine, there were 3 suicides in the experimental group.
Correct, yeah, correct. How many in placebo? None?
There were no suicides. I don't believe there were any suicides in the placebo group. It was
Dr. Mandela's right. I'm talking primarily about serotonergic psychedelics in the trials.
That's not a botanical. I understand.
Yeah, right. Well, I think when I made that statement about clinical trials, I was thinking psilocybin,
Yep.
MDMA.
Yep.
Were you right with ketamine? And I don't think there's been a clinical trial of ibogaine, but there have been people that have died in quote-unquote clinical settings with ibogaine.
There's a huge difference between dying in proximity to consumption of an agent and dying because you took that agent.
True.
Many people have problems after they cross the path of a black cat or go under a ladder. Well, most of us realize there's no real causal connection.
Sure.
It's much harder to defend that where biochemistry or
Yeah.
neurochemistry is
Yeah.
concerned.
Yeah, I mean, okay. What if someone did have a heart attack on psilocybin? Someone had a heart attack eating at the Cheeseburger Cafe in Las Vegas. No one was thinking that cheeseburgers caused their death, even though it probably did. Right? All right. Psychedelics and mental illness. So overall, it does seem that psychedelics fortify positive mental hygiene. They seem to increase mindfulness. They seem to help heal mental illness, but there are some risks as well as notable exceptions. So when we look at just observing people using psychedelics in the general population, they actually have lower rates of mental illness. This is an association. This is not a causative type of thing, but certainly is reassuring to see that it's not higher. In prison populations or forensic populations, the prisoners that get released that have used psychedelics tend to go back to that jail or prison setting less. So it seems to decrease the rates of things like property crime, violent or domestic types of crimes. Really the only type of crime that it didn't reduce was selling drugs. Amazing. Which is kind of comes along with the territory with the legal psychedelics, I guess. Psychedelics, at least at this point, are contraindicated in schizophrenia or bipolar disorders. Based on existing trial data, people with depression, anxiety, obsessive compulsive disorder, life-threatening illness like existential crises or substance use disorders are potentially candidates. While people that are in the clinical studies are treatment refractory, they are typically not the most severe cases. So treatment refractory is usually defined as failing 2 antidepressants. It's not that difficult to do. A lot of the clinical trials also exclude people that are acutely suicidal or have been suicidal in the last 6 months. So they're kind of cherry-picking people that have not gotten better on antidepressants but have not been so ill that they've at least recently thought of wanting to hurt themselves. And again, the ketamine data is a bit different because ketamine is just farther along. It's approved. They study it in suicidality now. Specifically, they're looking for it. Yeah.
I just wanted to comment.
Yeah.
Yes, ketamine is way further along, and I love it. And the reality is, there's nothing special about ketamine, except that ketamine was the most widely used anesthetic in the world in 1973 when the war on drugs started, and all these things got rescheduled, and they weren't able to reschedule ketamine. So ketamine remained fair game for research and data collection, unlike any of these others. Now, I'm very partial to ketamine, but the reality is we don't know where ketamine fits in because none of these other drugs have a database.
Yeah.
So we'll have to discover that, and they have great promise. But what I wanted to just call your attention to this contraindicated severe mental illness such as schizophrenia and bipolar disorder. Bipolars, particularly depressed bipolars type 2, do phenomenally well with ketamine and should not be deprived of ketamine because of a concern. Bipolars who are manic or profoundly hypomanic or frankly manic should not have these drugs. Now, there's a lot of nuance here, and people with rapid cycling, or what they're now calling mixed states, in modest doses, sometimes are able to sort things out way better with ketamine than without. But just generally speaking, if they're severely hypomanic or they're manic, you should probably defer infusions. And if they're depressed, infusions may really help them to get on their feet.
Have you ever seen someone convert to mania from ketamine therapies?
I have.
Yeah. So that would be another, if you're gonna, because that's essentially, I get a lot of, I have bipolar disorder, I want to use psychedelics, and it's like, okay, are you depressed? Yeah, okay, ketamine, right? Because that's sort of where, again, because we just don't know, right? It's like essentially like, okay, well, I do have data for depressed people with ketamine that are on mood stabilizers that works, right? I don't have that for psilocybin. Do I suspect that if you're a bipolar 2 and you use psilocybin in the daytime and didn't mess up your circadian rhythm and did it with a guidance, could it be very therapeutic? Probably, but I'll wait for the data.
But don't withhold treatment from profoundly depressed people because they carry a diagnosis of bipolar disorder.
Right, right. I think I give lectures to a lot of different audiences, right? And I think that the standard audience that I give it to is not at the level that they can assess the mental status of somebody. So I basically lecture from the perspective of this is a word that somebody's going to give you, and you're just going to have to make the best decision you can with those words. But right, when you are a physician, there's an ability to kind of evaluate these cases, because there is so much. Oh, I have bipolar disorder 20 years ago or 10 years ago. I was also using a lot of cocaine at the time. You know, it's been this many years. My therapist never thought I had it. At this point, I've been off mood stabilizers for 2 years. I haven't had a manic episode. Okay, yeah, you sound like you're probably fine. Versus, right, you're hypomanic currently or worse. Okay. So there's a lot of people that are interested in psychedelic healing now with mental illness, and overall I think this is a good thing. But desperation tends to increase people's vulnerability. Underground psychedelic healing has so many beautiful, earnest, amazing people that are involved with it. But the community is also rampant with these stories about charlatans and womanizers and things of that nature. Really, plan your experiences. For better or worse, right? Pollinated the peoples. So they all know about psychedelics now. They all want to use it, but they're not yet legal, and there's probably not enough trained people to kind of help. So it seems that I think that this is going to continue to worsen leading up and upon legalization is like, okay, so at this point there's kind of like, okay, there's you can take this drug that works maybe a coin flip of the time after 6 weeks, and in that first month you might get a headache, some upset stomach, and some extra anxiety. Or you can take this drug and you may see God and have a mystical experience and wake up feeling way better, right? So it's like, which one sounds better to you? I mean, I'll take the God and the mystical experience, yeah? So you have so many people that are interested in it that might be, I've been trying these things and they have not been working. Some people it's kind of like a last resort, or I'm at the end of my rope, or I read about it in the news and now all my eggs are in this basket, right? So that's probably not a great mental state to be in. Right, when these people that are desperate go to look for somewhere to take psychedelics and they Google drink ayahuasca near me on the internet, what comes up is inner mastery, right? Like what comes up is the most in-your-face types of retreat centers, and I'm not here to say advertising is good or bad. I'm just here to say that the ones that are the most visible oftentimes are rumored to not be the best types of programs or have the person's healing at heart. So I think that, this community, I think, is very much invested in keeping people safe, but, just continuing to do that, right? Continuing to sound the call on places that are just advertising to get as much people in and make a meal out of it and things of that nature. So again, they're on an SSRI. Does it interact? Yes, but what about their depression, right? Like, what about their kind of mental status? What about their mental history? So we got 2 people with depression that are on an SSRI here. One has been on and off meds for 3 years. She doesn't really feel attached so much. No history of suicidality, never been to a psych hospital, and it seemed that the issue was this brutal divorce which finished up a year ago, so ready to move on and do some more healing work. Person B, they've been on meds for 12 years, They're very attached to them, sensitive to withdrawal. They tried to kill themselves twice. One of those times they actually landed in the ICU because the blood loss was so severe. Been to a psych hospital 3 times, and they're in a relationship where the person's continuing to cheat on them, right? So it's kind of like just thinking about, all right, like, and again, I'm not here to say that you should not help person B or you should help person A. You're kind of thinking about it. If you're in this healing game, if you're thinking about doing work with people, all right, if they, you know, both of these people may not be on antidepressants, so they may both look like, oh, they're on antidepressants, so they're great candidates. And you know, what's just your level of comfort? What's your kind of skill sets? Like, who do you feel that you can truly support? Realistic expectations, again, I think that people kind of get this, is that, you know, the headlines, it's all, I met God, it cured me of my atheism, and I just woke up healed. It seems that most people that I talk with, they do get some good symptomatic relief, they do get some major improvements, it does happen quickly, but there seems to be unfinished business, more work to do, things they want to continue exploring afterwards. So this is a path, it's a journey, it's not necessarily just a one-shot deal that's going to make you better. It might be, I hope it is, but you know, just realistically don't expect that. Extra pharmacologic support, so some of these trials, right, they're doing 4 to 6 hours of psychotherapy before, between, and then after each session. Some of the times they're actually giving them a placebo or a niacin type of pill instead of the psychedelic, but they're still giving them the psychotherapy, right? Even for that placebo experience, right? So sometimes for one psilocybin journey, they're getting 18 hours plus worth of psychotherapy. So, you know, set and setting, that probably makes a difference. That's a huge amount of support for this type of intervention. So oftentimes, you know, people calling, it's like, I don't have the money, I got an 1/8 of mushrooms, I got my guide, I'm good to go, right? And it's kind of like, okay, well, it sounds like your acute experience is set up safely, but if you're really trying to achieve this therapeutic endpoint, I don't know. We don't know how much support is necessary before and after, because they, you know, so far haven't let us run a trial that doesn't feature much of this or allows you to compare types of psychotherapy or amount of psychotherapy. And I think like how much additional support is a major unanswered question, but probably some additional support is absolutely necessary. And I actually think that this support probably should be available for the person that's trying to do something therapeutic with microdosing as well. Seems like I meet a lot of people that's kind of like, I tried it twice and I had this pleasant mood uplifting effect, and then the 4th, 5th, and 6th time, all of a sudden the anxiety came. It was kind of like, okay, so essentially you were on sort of a light, protracted psychedelic experience over the course of a month, but when the anxiety came up, you just saw that as an adverse effect, a side effect, and you know, weren't working with anyone at the time to kind of like reframe what's happening to you so that you can kind of move the chains a bit. All right, this interface now, a lot of psychotropics do have risks in combination. Probably more often than risky is diminished intensity of effect or diminished intensity of experience. Tapering the psychotropics can be difficult. Sometimes you're dealing with withdrawal syndrome. Sometimes you're dealing with a return of a kind of the underlying symptoms or illness. A lot of the times it's both, because the person's on the medication and they're physically dependent on the medication, but the medication's not doing everything that they're hoping it will do symptomatically. So they're dealing with symptoms as well as coming off of this drug right now. A lot of them seem to have, or psychedelics and the mental health meds seem to have sort of these almost divergent mechanisms, in that it seems that the point of psychedelic therapies is to bring up the repressed, to you know, take what's dark and bring it to the light, to kind of shake up the snow globe, to agitate things and kind of see where they fall. It seems that most of the psychotropics, or I mean, none of them cure mental illness. They decrease symptoms. They maybe make you more functional, so that's the kind of upside or positive to them. But decreasing symptoms and making you more functional, how are they doing that? It depends how you want to phrase it, right? You could say like it represses emotions and makes you more tolerant to difficult situations. That would maybe be a positive way of framing it. Oftentimes you hear people say, it made me a numbed out zombie, right? So that's kind of like the negative way of saying it. You could say like, oh, a zombie is pretty emotionally tolerant, right? Yeah, so 6 of one, half a dozen of the other, if you like that effect or not. And then potential for counterproductive effects in combination. So if you have something that kind of represses emotion with something that brings it up, that doesn't sound like the greatest idea. On the other hand, right, if you are, well, this psychedelic it's you know, I have to do this kind of transformation in my life, and change is hard, and you know, like maybe something could help me deal with the stress of change. I'm not really sure. Again, I think my hunch and intuition is that it's mostly counterproductive, but I don't really want to just say that as the absolute truth, because again, I'm not sure that we truly know. And I think part of me as a mental health pharmacist wants to find ways to sort of, I see all of these things as tools, and just allow people to use the tools in ways that keep them safe and help them, and be less attached to which tool is the right one. You know.
Do you include benzos as a psychotropic?
Yeah, not one I particularly like, but I include it. Yeah. So a lot of psychotropics diminish effects of psychedelics. This isn't necessarily, maybe this means you want to taper, stop, discontinue, hold the drug. Maybe it doesn't. Probably depends on how much it diminishes it, right? If it diminishes if an SSRI diminishes the effects of MDMA by 80 or 90%, I mean, that's just not worth it. Whereas if an SSRI diminishes the effects of psilocybin by 20 or 30%, well, gosh, maybe you don't have the +4 experience where you meet God, but maybe you have an emotional catharsis where you cry for 3 hours and you do feel better, right? So kind of thinking about, again, and that's where we're missing a lot of data, is how much does it diminish the experience? Like, we have a fairly good idea that it's not the best in combination, but is it still worth it? Could they still get something good out of it or not? Others just are potentially dangerous, and obviously we're not going to do anything dangerous physiologically. So drug tapering is that, you know, there's so much, the community's abuzz talking about integration. You know, preparation also gets a fair bit of mention, but you know, I kind of feel that, you know, really getting to the place where they ingest the psychedelic drug could be harder than the psychedelic journey and the aftermath for some of these people that are coming from the world of traditional psychotropics and pharmaceuticals. So if you're in the world of integration or integration therapy, I would urge you to use those same emotional support tools to support somebody through a taper process, and that can actually be, you know, part of, you know, I don't prescribe the taper. You got to do that from your doctor, but you know, I will be a person that can emotionally support you and kind of deal with the challenges that are coming up, and helping the person frame what's coming up in this withdrawal as practice for their experience. Oh, you're crying every day? Surrender to the crying every day until we get you to this journey, right? Instead of being, I'm crying every day, I'm really bothered by it, I want it to stop now, what can I take to stop the crying? You know, can I plug the tears somehow? Let them flow for a while. To taper or not to taper, so these are the kind of questions that I ask people routinely. You know, what are their benefits and side effects of their current drug regimen? What are their goals? You know, sometimes it's sort of like, I'm on an SSRI and Wellbutrin and a big dose of benzo, and I think I'm just going to stop them all in the next month and then go to South America. It's kind of like, well, stopping 3 of these medications at the same time might be intolerable. Like it might be, you might be setting yourself up for a crash course here, and maybe you do make it through that month, and you know, maybe you do make it to a psychedelic, but then afterwards, if things aren't going well, you're not going to have any clue, did the psychedelic not work? Am I not the right support? Am I just in withdrawal from all these drugs still? So, you know, maybe things need to be done over a longer period of time and a bit more sequentially. what's the compatibility of their current meds and their psychedelic substance of interest? What are the balances and risks / benefits of stopping? So in a nutshell, the risks would be the withdrawal and the return of their illness or symptoms. The benefit would be that maybe they have a more potent psychedelic experience and the potential for healing is deeper. Taper probably should be done with the oversight of the prescribing provider. There are some good self-help resources as far as the person can look up a rated taper, and occasionally you do meet doctors that are not interested in helping people taper off. They're kind of, this is your third depressive episode, the guidelines say continue SSRIs forever. The last time we tried to taper off, it didn't work for you, so we're not going to try that anymore, right? So some people unfortunately do run into prescribers sometimes that aren't willing to work with them. But I always urge people, hear them out. What is their reason for not wanting to do it? Because they actually, opposed to me where I'm talking to them on the phone, it's the first time I've ever met them, their prescriber might know a lot more about them and, they might have a good reason. Tapering versus holding. So tapering aims to ultimately discontinue the drug, whereas holding would aim to suspend the use of a drug temporarily. So medications that maybe have lower risk for significant interaction and maybe don't have such a withdrawal syndrome, maybe it's just reasonable to hold it for 3, 4, 5 days around the time of their psychedelic session instead of having them complete the whole taper process and stay off of it. The rule of thumb here is about 5 half-lives. A half-life is the amount of time it takes the body to eliminate 50% of a drug. So if you wait 1 half-life, 50%'s gone. You wait 2 half-lives, there's 25% remaining, half of a half, or 75%'s gone. So the kind of standard rule of thumb is after 5 half-lives, there should be around 97, 98% of the drug should be eliminated from your system. And for all intents and purposes in the world of pharmacology, we kind of assume that the drug is eliminated at that point. Drugs can leave, they have withdrawal syndromes, right? Yeah, so the drug's gone from your body, you could have a withdrawal syndrome that lasts much, much longer than that. So I kind of think of it as okay, these drugs can affect you for longer than they stay in the body. So they have this kind of residual energetic signature to them. And I specifically use this because I think the kind of animistic philosophy of drugs having spirits is very much alive in the world of plant medicines. Psychedelic work is essentially energy type of work in a lot of ways. So kind of thinking about, well, just because a drug's eliminated, is it really gone, or is the spirit of that SSRI living on and going to continue to cause some withdrawal? And again, I think this is where, as a facilitator, maybe you have some wiggle room, and then maybe it's up to your own philosophy to kind of think about it. It's all right, yeah, I get it. The Xanax is gone in 48 hours, but that's not long enough for a person to kind of have gone through some things around their use of the Xanax, and maybe they need to kind of space it out and be a little emotionally raw for a while. And maybe actually I like to, okay, 5 half-lives plus 2 weeks is just kind of my standard, because I want that extra 2 weeks to kind of gauge their stability and check in one more time off of all the medications before we do this thing.
Can I have a question?
Yeah.
The normal half-lives that you see on like Wikipedia or Hippocrates or something like that, are they considering the secondary metabolites?
Usually not. Usually not.
Okay.
So this is a good question that Joseph brings up, is that some drugs have active metabolites to them. Sometimes yes and sometimes no. I bet if you looked up half-life of Prozac fluoxetine, I bet that in that Google search there would have the half-life of norfluoxetine kind of in that kind of initial answer thing, because it's just very well known that it has a long-acting active metabolite. If you did that for trazodone, I'm not sure that you would get it.
Which can then stack on a couple of days even, right? Or something.
Yeah.
Okay.
Okay.
Exactly. right?
Or ketamine.
Or ketamine. So ketamine's another one that's sort of like, okay, you give an infusion of ketamine, you're not depressed 4 hours later. You see a very rapid type of effect to it, and there's all sorts of, is it right? Is it the neurotrophic factors and the kind of upregulation to it? Is it actually a metabolite? Is it hydroxynorketamine, like the HNK metabolites that are leading to these antidepressant effects that are eliminated longer? You know, same thing with like, okay, maybe it's ibogaine that is delivering the majority of the kind of psychedelic journey that gives them some insight into the etiology of addiction. There's probably that long-acting noribogaine metabolite that sticks around for 4 or 5 days afterwards that is helping them taper off of their opioids or blocking those opioid withdrawal syndromes for another 4 or 5 days after that initial ibogaine. So metabolites in certain situations really do matter a lot.
They may also introduce structural changes that persist long after the drug is out of the body.
Right.
In certain laboratory animals, ketamine produces new growth of new connections to parts of the brain and increased receptor density, which is easily demonstrated. And that persists for weeks to months after.
Yeah, right. So this kind of neuroplastic state, DMN reset. I forgot I had the slide because I literally just said all of this. It was on the slide. Sorry. Okay. I planned to be done 15 minutes ago. How does that happen? So these are some common types of psychotropics. Actually, painkillers usually aren't listed in psychotropics, but I don't know. I do what I want. These are the types of psychotropics that people are on, typically that have things like depression, anxiety, PTSD, OCD. So these are the kind of psychotropics that you're probably going to see as most standard types of things for people that are reasonable candidates for serotonergic psychedelics. These are usually for bipolar disorders or schizophrenia. Again, you know, if you have a bipolar depression, you're on a dose of a mood stabilizer. Again, these aren't perfect rules. These are just kind of rules of thumb as far as like looking at medication classes and doing a little bit of reverse engineering. Pharmacy is about reverse engineering. I usually start by looking at a drug regimen, and then I'm kind of like, okay, what disease states do I think I have? And like, so it's the opposite. The doctor's process starts with the person and the symptoms and tries to get to the diagnosis and the treatment. I always start with what the treatments are and sort of working backwards. Okay. So this chart is highly reductionist, yet I think is fairly accurate for the moment. I think some things will change in the next 10 years. So maybe we'll just kind of go through this and then open it up for questions. I have some more slides afterwards that are kind of just going through the different medication classes, but this pretty much sums it up. The colors, red, orange, green, has to do with physical things, so physiological types of safety. So green doesn't necessarily mean it's a great idea psychologically. It just means that you're not going to run into severe physical toxicity like serotonin syndrome. Where obviously the red is that there's kind of a potential severe risk possible. The ups, downs, plus or minuses, question marks, these have to do with psychological effects now. The double down is just extreme diminishment or extreme attenuation. I didn't put it in the key. So what you kind of see now, and we'll kind of go both ways. So the SSRIs, let's look across the board here. It looks like MDMA, yeah, we know it diminishes the experience. Other tryptamine psychedelics, it seems like it's a bit of a black box. Some people get a pretty good effect. Some people do report diminished effects or experiences. Ketamine, no issue. The original trials of ketamine had people wash out of their antidepressants. S-ketamine is labeled for use with antidepressants. So it seems like the labeling that they have on S-ketamine is that indicated for taking with antidepressants. But the reality is it doesn't necessarily seem to impact it so much either way. Ayahuasca and ibogaine, you kind of start to notice that with the exception of benzodiazepines, there's not really many psychotropics that are necessarily a very good idea, and those are definitely the two psychedelics that you probably really need to have some more than basic understanding around interactions with drugs if you're going to use them in people that are taking drugs, definitely. Benzos. They're not dangerous, but they just kind of put the damper on everything, right? Like, so the benzodiazepines are known as trip killers on the Reddit threads. If you're having a bad acid trip, 2 hours in, you don't like it, you just take some Xanax, according to these different threads, and within 30, 40 minutes, okay, maybe you're not completely at baseline, but a lot of the anxiety is gone, the kind of edge is off, and in hallucinogen research guidelines, they actually say that you can use a benzodiazepine as kind of the last resort for someone. So first line is someone struggling and experiences is emotional support. That's not working, and or the situation becomes unsafe. And I think that would be the one, more than like kind of like they're still panicking. I would continue to just do emotional things. But when it gets to the point of, wow, they're throwing things, they're hitting things, they might hurt themselves, they're charging around, that's when, at least in these clinical trials, they may consider using a benzodiazepine. If that really didn't work, they also have antipsychotics written in there, but to my knowledge, they've never even used a benzodiazepine in the clinical trials to really, at least acutely, take the edge off of an experience. Some of the vets that had taken benzos before the MDMA trials did use them for anxiety or insomnia and kind of week afterwards, and it didn't seem to kind of ruin their therapeutic effect. But what else? What else about benzos? Benzos, beyond diminishing psychedelic effects, benzos are just not the therapist's friend, in that they tend to make therapy processes less effective, and this includes trauma-based therapies. So if you're kind of thinking about like, okay, this person is going through a psychedelic-assisted psychotherapy, the psychedelic experience is potentially diminished, and their ability to kind of participate in the therapy sessions is also potentially kind of compromised. You can kind of really see that, maybe they're just really not going to get as much out of this as I was kind of hoping for.
And I had a comment on that.
Yeah.
There's something I picked up in my postdoc, I don't remember where I got it from, but that like benzos essentially like block the unlearning, the cognitive unlearning of fear. So if you're trying to do like exposure therapy or a psychedelic that's like literally kind of reverse, drawing the roots of the fear cognitively out of the brain, like the benzos are like blocking that unlearning process.
Well, I think they're very much so. I think they're blocking learning and unlearning. Mm-hmm. Like, I think they're just kind of like this firewall between taking in new knowledge or retrieving knowledge from your memory. And it's just kind of, if you kind of think about, right, if you drink too much, you black out. You get an interrograde amnesia. Same thing with benzos. If you take too much, you black out. You get an interrograde amnesia, and you don't necessarily...
You have a memory link or something? Maybe?
Yeah, so I kind of feel like, right, it's sort of, you're blacked out, you can't put anything into memory storage, right? And we're talking about the opposite effect, essentially, is like retrieving a repressed memory and bringing it up for therapeutic processing.
Yeah.
So, maybe benzos are good at kind of keeping the lid on the trash can, but you just can't stuff that trash down forever. You got to take it out once in a while.
Question, Ben?
Yeah.
Where does alcohol fit in as far as working like a benzo to cut, let's say, a difficult experience?
Ooh. I guess it would probably work, right? It's like, okay, I'm having a kind of a panicky experience. Should I take a shot of vodka to calm myself down?
Right. And I think it would be faster, perhaps, as far as working.
Oh, would it be faster?
Depending on how full their stomach was, maybe.
Maybe.
So what about the
You
effects
snort
on the
some
liver?
Xanax.
I just don't think it's a great strategy either way, yeah.
I think alcohol could exacerbate the situation.
It
It would
could.
not I would say one thing that hasn't been mentioned that I've seen quite useful in raves is high-dose sugar.
Huh.
I don't know if other people have tried it. Tea with a lot of honey or an intravenous with D50 help to really bring down people who are just, their executive function is gone. Help to bring
Well, that's also consistent with kind of shamanic interventions, right? Using salt or sugar
Yes.
to...
Also magnesium, clouds magnesium works really good sometimes.
I was gonna say from personal experience, like I have a lot of experience with recreational ketamine, especially when I was a lot younger. And like among my friends group, it was like, if you're having like a really bad time on ketamine and you took like way too much and you for like someone shows up and you need to like come down really fast, you just eat a giant candy bar. And it helps so much. Like if you like need to go in the car and you're too high and you know it's gonna make you car sick, eat a giant candy bar. It just helps.
Interesting.
They do this in Africa with Iboga too. They give you a spoonful of honey.
All right, so don't whip out the Xanax. Get out your king-size Snickers.
Speaking of king-size Snickers, where does cacao fit in all of this?
Cacao? I couldn't tell you off the top of my
So
head.
it has some malin-fitting.
Yeah, is it theobromine? Is that a MAO? That's not the MAO inhibitor, though.
I
Is it?
do not know.
If it's a MAO inhibitor, it's a pretty weak one. Because I'm not aware of much in the way of any dietary restriction if you're taking cacao. I'm not aware of SSRIs in cacao being problematic at all. So maybe there's an effect, but I don't think that it's a dangerous one.
It has mild potentiation of mushrooms.
Sure, yeah. I mean, I think coffee also has some mild MAO inhibitors in it. Monoamine oxidase is one of these enzymes that there's so many things that very weakly interact with it or change its function somehow, but there are things that just truly knock it out. The harmalas and the pharmas are probably the strongest ones. But, yeah. Stimulants. So stimulants, dangerous with ayahuasca or ibogaine. Stimulants are probably some increased risk compared to like a benzo, but I think it really just kind of, this chart assumes moderate or therapeutic doses, right? So it's like, okay, yeah, methamphetamine and ketamine at the rave, yeah, there's been some harm associated with that. The person that's taking 20 milligrams of Adderall XR, can they use psilocybin or something? Yeah, they probably can. Like, that's probably not excessive risk. MDMA is a stimulant itself. Right? MDMA is methylene, doxy, methamphetamine, and many other, I mean, phenethylamines all are. So any of those other MDMA, 2CB, the NBOMs would probably be too dangerous for my liking with a stimulant. I would maybe not have them taper or discontinue if that's not what they wanted to do, but I would have them hold it for at least 24, 48, 72 hours would be better beforehand and maybe 24 after.
Where would you put 5-MeO on this?
5-MeO, which one would I put, which box would I put it in?
Well, if you had a column, what would the rows look like?
5-MeO and NN-DMT are kind of outliers where I'm not really sure where to put them. The serotonergic psychedelics like LSD, psilocybin, mescaline, even MDMA, they have some cross tolerance between them. So you kind of, all right, they do pretty similar things that have cross tolerance. NN-DMT has no cross tolerance with LSD, and I suspect that 5-MeO doesn't have so much cross tolerance either. 5-MeO DMT is structurally a tryptamine, so it kind of like makes me want to put it in this category, but none of these other tryptamines, psilocybin, LSD, or DMT, are dangerous with MAO inhibitors, whereas it seems like 5-MeO DMT really is dangerous with MAO inhibitors. 5-MeO DMT is maybe different than some of the other tryptamines in that If you look at psilocybin, LSD, or DMT, is how strongly do they stimulate that serotonin 2A receptor using serotonin as a reference, it seems like all those tryptamines stimulate the receptor less strongly than serotonin, at least in the standard canonical serotonin pathway. There are other sorts of functional selectivity things with these that we're not so sure about, but at least with serotonin as a reference, all those other tryptamines are less strong at the serotonin 2A receptor. At least in rodents, 5-MeO-DMT is stronger than serotonin at the serotonin 2A receptor. Similar to amphetamine, 5-MeO-DMT can also very weakly inhibit the serotonin reuptake pump. So why does NN combined with Harmala lead to the safest and most therapeutic, awesome cosmic journey ever, and 5-MeO-DMT and these Harmalas lead to a potentially toxic and serotonin type of syndrome? Well, NN definitely does not inhibit the reuptake of serotonin, and that would be a very classic way with MAO inhibitors to run into issues. Maybe it's just strong. Maybe it's just stronger than serotonin itself as far as the signal that it produces. NN-DMT, it's metabolized by monoamine oxidase, but it's also metabolized by some kinases, so it has metabolic backdoors, it has metabolic outs to it. 5-MeO-DMT is metabolized by two enzymes that we know of, monoamine oxidase and CYP2D6, and the Harmalas inhibit both of those. So basically, Harmalas and 5-MeO, you cut off both metabolic routes, monoamine oxidase as well as CYP2D6. 5-MeO has some weak SSRI or serotonin reuptake to it. 5-MeO also seems to be stronger than the other psychedelics at the serotonin 2A receptor, and all of these things, I'm not sure which one, but seem to have led to the perfect storm in a couple of anecdotes. So where would I put it? Although it's structurally similar to psilocybin, LSD, DMT, I would probably treat it more like a phenethylamine, because the phenethylamines truly are dangerous with MAO inhibitors. But you see, most of these columns, I mean, they match up pretty well. So I mean, I would definitely put it somewhere over here. But which one is it more similar to? I'm not sure. Or is it really should have its own column? Maybe it should have its own column. The opioids. So there are some with ayahuasca that inhibit the serotonin reuptake pump, are going to be really dangerous. There are, opioids and ibogaine, just don't do it because you're trying to get off opioids, essentially, is why you're using ibogaine. Ibogaine also resets your tolerance to probably many addictive substances, including opioids. So using opioids under the influence of ibogaine or directly after ibogaine is extremely high risk of overdosing, and just, I mean, it just therapeutically makes no sense because you're probably trying to do the opposite. Opioids aren't necessarily dangerous with things like MDMA or psilocybin. Probably depends on the opioid user. You know, some people are taking moderate doses, they have a tolerance to that, and it's, they're just normal. They're functioning normally on opioids, so it's probably not going to be that big of a deal for them. You know, other people are on really high doses, or maybe are not looking at this chart in the wrong way, because this chart again is assuming therapeutic use, right? It's sort of, oh, maybe you're not on opioids and you're kind of like, what would happen if I took oxycodone and mushrooms tonight, right? Well, you're probably going to get a synergistic type of effect because you're just using two strongly psychoactive things that you don't normally use together, right? The antipsychotics, I mean, a lot of these were engineered to be anti-psychedelics, in that especially the atypicals or the second generation antipsychotics all block serotonin 2A receptors. The mood stabilizers, there's just really not a lot of data outside of ketamine and lithium and Depakote. There's some trip reports on Arrowwood about people having seizures with LSD and lithium. So I have not really, I've just said don't do it with the lithium and serotonergic psychedelics. Also primarily because the person probably has a bipolar disorder. Occasionally I run into people taking supplements like lithium orotate. So these are like very, very small doses of lithium. And lithium is actually found in the drinking water. It seems like the dose of lithium in lithium orotate is about 3 to 5 times the amount that you would find in regular drinking water on a daily basis. Whereas the doses that they're using in bipolar disorder are kind of more like 100 to 1,000-fold higher. So I think lithium orotate is probably pretty low risk, but I've also not met anyone that's had a problem just stopping it for 48 or 72 hours beforehand and getting rid of most of it before they do a psychedelic. So I have many more slides here just on different classes of things. It's more just repeating what I just said. Seeing that it's 7:45, I want to hear from you. I want to know what your questions are. I want to kind of, I don't know, I think wrap it up here and open it up for some discussion. Yeah, I think that'd be good. Yeah. Oh, wow.
I have a question.
Yeah.
How do you explain, I've had some clients or just friends talk about this diminishment, like even 3 months after stopping an antidepressant with psychedelics, or 6 months after.
Yeah.
Is there any like pharmacological reason why that would be?
Really, the neuroadaptation event would be the only okay, if it takes 6 weeks for an antidepressant to have a therapeutic effect, maybe that effect does involve serotonin 2A receptor downregulation. Maybe it would take a similar amount of time to reverse that. Not sure. Or, you know, this is what kind of, or maybe just depression itself is just hard. Maybe depression and OCD are right. I mean, because we think that the psychedelics helps to kind of loosen this really rigid thinking, but I feel like there's a lot of rigidity that makes people want to stay in control, and I don't know. I'm not really sure. It's a great question, and I'm not really sure if it's sort of like, I feel like I've met these people. It's kind of like they've been off for 3 months. Their mind should be blown from this, and it's not. And I don't know why. Mm-hmm. And then I've met other people that's kind of like, I was on my SSRI and I took mushrooms and I had the most mystical experience.
Yeah.
It's very weird.
I hadn't heard of that. So the 2A receptor shift, has anyone documented like how long that persists? Because now they explain it in terms of the...
I would explain it.
So in that slide,
Yes.
I'm trying to remember, it's taking long-term SSRI that fundamentally alters the structure of the 2A receptor.
We think it because the body's very smart. So when you have more neurotransmitter, usually the body wants less receptor because it wants to kind of restore the same signal that it had before. So the body's temptation, if you did block the serotonin reuptake pump and lead to more serotonin, I think the body's temptation would be to downregulate the receptor, and there's been some documentation of that. There's also been documentation that psychedelic use leads to rapid downregulation of the serotonin 2A receptor to the point where we actually think that that might be part of the therapeutic effect, is that you have less of this receptor available. But yeah, this is exactly why we want to do this online survey, because it's just kind of like, what is the deal? Is it particular agents? Is it particular durations of time? Is it, I don't know, is it the wrong dose? Is it what is it? Because some people, they get good effects and some don't. Yeah.
I think it has to do with emotional resistance. You know, I think this is the missing piece. We all know kind of what I do is providing the emotional aspect and emotional alchemy. You get through this. So it's sometimes not dependent on the substance. The person's resistant.
Right.
Not wanting to taste things that
Right.
completely block themselves.
Well, that's what. It was a very interesting read that the person from, was it Saj, the person from NAPATH wrote that article about dissociation and PTSD, and that sometimes in his perspective or observations that people with PTSD that take MDMA, sometimes nothing will be happening, and it's because their ability to dissociate from overwhelming stimuli is so strong that when the psychedelic starts to take effect that they just dissociate. That they're actually having a psychedelic experience, but they're completely dissociated from it.
He also had a a quote from Bessel van der Kolk that,
Yeah.
that, you know, I guess more with veterans, that their body could create up to the equivalent of 8 milligrams of morphine.
Yeah,
which is
so
kind of
so that one,
interesting.
I read that one, I was kind of thinking through, and it's kind of like, do I believe that the body's naturally produced endogenous opioids equate to what morphine does? And the answer is no, I don't.
Mhm.
I think endorphin and dynorphins and enkephalins work on opioid receptors, but fundamentally do something different than what morphine does as far as the level of apathy. Because you could make the same argument that kind of like, okay, so you're telling me that if I just went on a big jog and I had a massive runner's high going with all these endorphins, that a psychedelic wouldn't work anymore? No, because I think it would actually be potentiated in that situation.
Right.
Right, so
But it could be, I mean,
it was a very interesting read
I
for
thought
me,
it
but
was
I was also a little bit like, okay, like
But I
there's
think
something
he's-
there.
He's talking about it in the same sense, though, as a way of explaining emotional resistance. I
Right.
guess, which-
Well, I believe what he's observing is real.
Yeah.
Like I believe that there's some people that are taking these substances that aren't really like in their experience for whatever reason. But yeah,
What's the article?
it's called, like, if you just search why MDMA will not work for you, it would probably be one of the first links. It's from Innate Path. Yeah.
Yeah, that's interesting.
Question with,
Yeah.
with benzos. It seems like with some of the, with SSRIs and stimulants, there's things that can help, like other supplements, or there's more established protocols, but with benzos, I haven't been able to find like things
Right.
that actually help or mitigate the withdrawal discontinuation process. What have you found over here?
Taper slower. Yeah,
Just go
sort of alcohol, which you're not gonna do. Switch to Valium, switch to the longest acting benzo and try to taper that. But as far as like, yeah, what supplement? Kava Kava would probably be like the closest one because it does work on GABA. The Selexin or the lavender oil in a capsule, I think indirectly works on GABA. I wouldn't really see the thing. People always want just something to replace what it. And it's like, no, you didn't like what you were on. Why do you want to replace it? Like, we've got to learn how to do something else. And I fully understand that like people want this like crutch to lean on as they go through. But my advice for people is if they're going through withdrawal and it's becoming intolerable and they're starting to look, I need something else, slow down your taper. Like, this is probably, I mean, you can still look for something else, but the thing that I absolutely know is going to make you more comfortable, is going to make the process easier, is slowing the taper. You know, taking a guess at a supplement that might mimic some of the effects that, okay, like if there's not that much risk to it, it's reasonable. But yeah, I have not, even SSRI withdrawal, right? Like there's, I mean, some people microdose and that kind of makes them feel a little bit better. I'm not really sure if it's handling withdrawal or just improving their mood. You know, there's the Canna, it's like some herbal SSRI. I don't have much experience with it, but some people are using it. Yeah.
Here's an opportunity for you to back engineer.
All right.
I had a client that had a long history of migraine, debilitating migraine, and came for a high dose psilocybin experience. We don't know what he was on. We asked him to taper whatever he was taking, but nothing worked for him, so it wasn't particularly one medication we believe he was on for a long period of time. He had no experience. 5 grams.
Yeah.
7 grams.
Yeah.
No experience. And we don't, any clue?
Benzos, antipsychotics, and antidepressants.
Any personality, incredibly controlled personality.
Yeah.
That's what explains to me.
So that's another, like in this Innate Path article basically says, like, person's dissociating in their experience, they're not getting anything. The trick is to just tell them to focus and sit with the dissociation until it breaks.
Right.
Right? Whereas I feel like the temptation for some of us might be like, well, You want to take a bong load? You want to do a line of ketamine? Like we need to kind of punch through this, right? Because there is, right? We don't.
You learn that's not it.
Yeah. That's not your strategy,
It's
huh?
just one of the two like that, we're just like still scratching our head.
Right. Maybe it has to do with genetics. You know, maybe there's something to do with like, maybe there's a common ground here, sort of like SSRIs aren't working for them and psychedelics aren't working them because they have just a genetically different serotonin receptor or something like that, and the drugs just don't bind very well. Endogenous serotonin may not bind very well, and that's why they kind of have some low mood. Maybe there is some use for this chemical depression of theory of depression, the chemical imbalance theory of depression, like after all. Like maybe there is like certain people out there that really do have like, I don't know, a very hungry monoamine oxidase inhibitor that chews through stuff, or, yeah. Let's go with Tara and then.
I was just gonna say that I thought I had read somewhere that like there's some small percentage of the population for which like for some reason genetically like psilocybin particularly just doesn't work for them. I've met one person like that. They're just like, oh, like, yeah, I don't feel anything. Like LSD, fine. Like I have effects on LSD, like mushrooms for whatever reason. Psilocybin.
That is bizarre.
Like, and then I feel like I read something about somewhere, but I can't think of where.
Yeah.
That would be a cool study.
Like that? Yeah. I'll look it up. I'll see.
I also met one guy a couple years ago that like I saw him like 3 times, and every time he came up to me, he was like, I can drink 10 cups of ayahuasca, nothing happens. I've done it like 10 times. It's like, what do I need to do? He's like, to tell me how to make it work. I'm like, I don't know. Like, try drinking more? He's like, I did that again. It's like, every time I saw him, he was like, I tried to, even more this time. And it's like, you know, and he's like, I tried drinking Syrian roux first, and then, you know, you're just trying all these ways, and it's like, for some reason, his wasn't working. Yeah.
We've had a very small handful of patients who get great response to ketamine, and then when they came back for boosters, had no response. Not a diminished response, no response. And I'm totally perplexed about that. If you have any thoughts, I'd love to hear.
Well, what's your policy around benzodiazepines and ketamine? Do you let people do them? Do you hold it the night before? What's your kind of...
It's a different story, and it's kind of nuanced. I think people get much more benefit if they're not on benzos.
Right.
Some people are unable to take infusions, not on benzos. And some people, particularly if they're suicidal, deserve a trial of ketamine even if they stay on their benzos.
Yeah.
Also, we give infusions over time. And maybe the initial infusions involve some benzo.
Right.
And there's a taper, a pretty aggressive taper. And your comment about if you're having a problem, don't look for all kinds of attenuating circumstances. Just slow down your taper. That's the best. There's no question in my mind, but there's not much data that benzos decrease the benefit of ketamine. On the other hand, there are patients who can undergo the experience without.
Correct.
So it's a balancing act.
This is exactly where I'm at on the benzodiazepines, is that some people, especially older people, higher doses, longer periods of time, they have horrible times getting off of them, to the point where, right, like a benzo taper can make someone that's never been suicidal. Like they're just really bad and hard drugs to get off of, right? And so you look at a chart like this, and it says, oh my God, across the board, it kind of diminishes the effect. But across the board, it doesn't look excessively dangerous. So this becomes a real sort of risk-benefit sort of discussion. And okay, yeah, if you take a dose of benzo right before your experience, it's probably going to be diminished. But what if, I don't know, what if you take half your bedtime dose the night before, right? What if you kind of come in a little bit, okay, you're not fully comfortable and so much GABA in your brain that you're half asleep, but at the same time you're not in a withdrawal yet. Or maybe you're engaged in a taper process And that essentially is already putting you in a state of relative GABA deficiency or glutamate excess. So you're kind of more excited. I think like ideally you want the person not like aroused, but but you want them, alert, a little emotionally raw is okay. Completely on the rocks and suicidal is probably not great, right? So it's like maybe just as long as that person is even committed to the world's slowest taper, as long as they're committed to a taper process, they're committed to doing their work, they're trying to make a step forward, right? So maybe you should work with them. Maybe it's sort of like, okay, like, yeah.
One of the great old physiologists of William James proposed, are we running because we're afraid? Or are we afraid because we're running? And the stories people tell themselves about the arousal. I'm anxious, or I'm excited.
Yeah.
It's some of the same chemicals in the same brain, just with a different narrative. And you can help patients as part of their mental set to change their narrative.
Yeah.
So they're not white knuckling it. It's not, oh, I have to take it or I'm going to jump out of my skin. It's, oh, I'm really experiencing a lot that I normally block off, and I came here to get in touch with that.
Exactly.
This is me.
And so this is exactly why I think integration coaches for psychedelics in reverse titration clinics, or having that be part of the emotional support package that you offer, is kind of like, I don't prescribe, I don't necessarily tell you to go up or down, that's between your doctor, but what I do is help you reframe this kind of psychological thing, because many physicians only have enough time to write something on a piece of paper and don't necessarily have the type of practice where they can do this psychological reframing for people. But yeah, terror and ecstasy, it's the same chemicals. It's just your story, right? That was from him. I stole that one from Richard.
I give it to you.
Yeah.
Explains our movie.
Yeah.
Yeah.
So a lot of it's consciousness, but I think it's the point. If they're capable of actually being present and conscious, then you can get them to be telling them that's the way to know.
Yeah.
If you can't,
You can. Yes.
I have a friend who he's got ALS, who's been bedridden for many years, and he communicates with use of a computer screen as Monoamine. And I've always wanted to give him the benefit of a psychedelic experience. He used to have experience. The problem is that you don't want to give a patient anything that increases his heart rate, say. And it seems that most psychedelics do. Do you think there is anything that could be possibly used for him? Sure. I mean, maybe like.
Why can't he increase his heart rate? Just because he's bedridden?
What's that?
Why can't he increase his heart rate?
Well, he's got something that helps him breathe, a machine, and to communicate, is not instantaneous. So he's kind of riding a fine line of survival all the time. I mean, maybe it'd be really stupid. I actually, at one conference, I asked Charles Grove about that, but he said, he couldn't think of anything.
Couldn't think of anything that doesn't increase heart rates and stuff?
Yeah.
Well, I mean, I do think that the psychedelics that I know of do transiently increase your heart rate. Actually, the one that increases your heart rate the least out of all of them that I'm aware of is ayahuasca. And it's mostly because DMT by itself does increase your heart rate a lot, but the MAO inhibitors drop blood pressures down. They tend to kind of negate some of the cardiovascular effects, whereas it seems like if you compare Strassman's data, or just IV DMT versus ayahuasca at like a strong brew, like a 1 mg per kg like brew, you get way more of a cardiovascular effect with the IV DMT than oral ayahuasca, and you get less blood pressure elevations from oral ayahuasca than psilocybin or LSD, and definitely less than MDMA.
What about microdosing?
You could pull the chakruna out also, just dry also.
Yeah, there you go.
If you wanted to do something, you might also, this is not advocating, but you could moderate his heart rate pretty substantially by pre-treating with a beta blocker.
This is the truth as well. That you could use clonidine or carvedilol ahead of time. They've done that with MDMA actually.
Yeah.
Yeah. Yeah. So there's a way. There's definitely a way.
We don't recommend that with ayahuasca.
Just because you can do something doesn't mean you should.
Yeah, I wouldn't. Yeah. Right. No, I wouldn't do it with ayahuasca. I would just say, like, if you really wanted to minimize the cardiovascular risk of something like MDMA or psilocybin, you could use something like carvedilol or clonidine.
Yeah.
I also just feel like if you're on a ventilator, I mean, the machines are built to keep people alive.
Yeah.
I guess it just depends, like how. Like, I mean, this person, they live in a facility.
They're at home.
They're at home.
Yeah.
Okay.
What about psilocybin with a beta blocker?
They got a respiratory tech that comes once in a while.
There's 24-hour care.
Okay. Are they friendly enough? You know, or another thing would be, I don't know, this probably doesn't make sense for your friend's situation at all, but sometimes you meet people that sort of like, they have some type of minor arrhythmia or cardiovascular condition, and it really doesn't seem so severe, but I'm not a cardiologist either, and they're kind of like, oh, I have a heart doctor. It's kind of like, ask your heart doctor what they think about you going on Adderall. See what they'll tell you about that, right? Because Adderall is a stimulant, just like MDMA, and you know, if anything, a doctor's going to think about Adderall and think, what do I think about chronic amphetamine use, opposed to like, what do I think about amphetamine use in one dose? So their answer is probably going to lean more conservative for that Adderall question, and you could probably get some really good insight from your cardiologist about how dangerous an amphetamine is for you just from that question without having to bring up the psychedelics. But if you have the relationship, I always just encourage just telling the doctor about it, like if they're not going to wig out and refer you to a treatment program or something.
Right. Thanks. Folks.
What do you think, Brad? It's been a real pleasure talking with you all, and yeah, I hope I can come back here in another few years and do it again. And thank you.
Pharmacist.com, is that
Yeah, yes. Sorry, there was at the very end I put it down.
I want to do a commercial for Ben. So he's been super helpful. If you have clients that are going to approach plant medicine, they're on medications, have contraindication, interaction questions before any plant medicine retreat center, for ketamine treatment, whatever, he collaborates with professionals, direct patient consultations, and it's been incredibly helpful to me and
Joseph.
my work. Yeah, thank you.
Actually, like this whole consulting thing wasn't my idea. It was Joseph's idea. Joseph just started asking me questions, and then he was like, I have a friend that also wants to ask you questions, and then there was like half a dozen people that want to ask me questions, and I was kind of like, okay, maybe we should have a question answering service.
Yeah.
So I really owe it all to this man over here.
Thank you, Joe.
And that man over there too. He's a good one. Yeah, thank you.